First of all, thank you for your kind introduction, and I want to thank everybody for attending this event. Especially, I want to thank Dr. Evidente, friend of mine that I know him for many years since he was at Mayo, and since that time, we continue our collaboration and relationship, and it's my real honor that was invited by Dr. Evidente for this event. And always when I have any, conversation and discussion about movement disorders, always I learn something from him. And not only is one of the most or smart neurologists and movement disorders, I have to say he has one of the most beautiful offices that I have ever seen. Always when I come here and see his office, I'm amazed at how it's decorated. So having said that, let's get to our discussion, which is the cognitive impairment in Parkinson's disease. And this is our agenda. Talking about this topic, I have to open up with Parkinson's disease and then touch on pathology and pathophysiology. And because we cannot get into the cognitive impairment in Parkinson's disease when we don't know what is the mechanism and what elements affect or get involved in Parkinson. To understand cognitive impairment, we have to understand first what is the cognition and cognitive impairment by itself, and then we can bridge to cognitive impairment in Parkinson's disease. Then I discuss how we manage cognitive impairment, non-pharmacological and pharmacological options. So first about Parkinson's disease. You know that here, that you heard it a lot of times, that is the most common or second most common neurodegenerative disorder. So there are two important elements in this sentence. What is a really important and common dilemma that we are facing, and it's gonna be more and more involved because with age is one of the main risk factor, and with the increase of age, we have more and more patients with Parkinson's disease. And as you see, I said second most common neurodegenerative disorders. Why is that important? Because that just tells us that Parkinson's disease is progressive disorders. It's different than some other neurological disorders, like, for example, epilepsy and seizure disorders, that if the patient with seizure is seizure-free, the last thing you want to do, you want to change the medication. So therefore, I don't get surprised if I see a patient with epilepsy for 20 years, they are on one epilepsy medication, and as long as they don't have side effect, and as long as they don't have seizure, the last thing you want to do, you want to change the medication. In Parkinson's disease, the other hand, because of that element of progressive disorders, if you were diagnosed with Parkinson's disease, let's say 20 years ago, and you do not have any more symptoms and everything is under control with medication, after 20 years, if nobody changed your medication and you're still doing well, maybe you have to sit back, go back to your doctor, see doctor, for example, any neurologist, and say that, hey, I think that is something wrong because I was told that disease will progress. So that's maybe you can question even if you have Parkinson, because Parkinson is supposed to progress. However, we can control the symptoms with managing the medication. So what symptoms? So symptoms are motor symptoms and non-motor symptoms. I'm going to show you the motor symptoms first. You see that the first one, slowness of the movement. That's the most important symptoms. Why? Because you cannot have Parkinson's disease if you are not slow. So to diagnose my patients with Parkinson's disease, I have to detect their slowness of the movement, which actually, in fact, a lot of times patients figure it out themselves and they come and say, doctor, I have some difficulty with my handwriting. I have a difficulty with my dexterities, depend on their job. Sometimes they work with computer, they say, I have a difficulty even, type or use the mouse, or if they are like a handyman, they say that, or at his, his garage and working, they say, I noticed that I have a little issue with using screwdriver. So what about if you're right-handed, but your left side is affected? Then your primary care physician maybe pick it up and say, I noticed that you don't swing your left arm, and let's go to the neurologist to figure it out. So you need, and then when your neurologist see you, he has to detect your slowness in your abnormal, basically, exam. And then you need one of the rest of these blocks that I made them colorful for you. You can have tremor, you can have stiffness, you need only one of them. And so obviously, you probably heard a lot, not everybody has tremor. And usually severe difficulty with gait and balance and freezing of gait happen later. And even I put it here as a motor symptoms of Parkinson's disease. I want to tell you in advance that these are the two motor symptoms that significantly get affected by cognition. So therefore, with the patients with cognitive impairment, we see that these two elements did actually get affected. So therefore, we believe that gait, in fact, is a cognitive task. So after these motor symptoms, I want to share you another thing that we, at least in the last 20 years, at least, there is no meeting of movement disorders that you can walk in and you don't see that. Again, at least 50% of the sessions belong to non-motor aspect of Parkinson's disease. And non-motor, as you see, I listed here, is head to toe. Maybe it was easier for me to say, just list what system is not affected by Parkinson's disease, which I can probably is none. Because as you see, depression and anxiety, I can remember any patient with Parkinson's disease that eventually they don't have some level of mood change, being depressed mood, apathy, lack of interest for doing things, or a little bit anxious and anxiety. So the good news is that we can easily manage that. So lightheadedness can be an issue, fatigue. With fatigue, we have a little challenge, sometimes can be difficult to treat. Sleep disturbances are very important in Parkinson's disease, and important is that if we can correct them, sometimes we can also help them with fatigue and also even their cognition. I put here drooling and difficulty swallowing. We list them as a non-motor aspect of the disease. However, I have to tell you, I believe myself that what causing them are motor aspects of the disease, because you drool because you cannot swallow well. So because motor aspect get affected, and therefore patients drool and have difficulty swallowing. Constipation, it's very common, dry mouth. Hallucination, which is not only hallucination, I can elaborate it more later, is a hallucination, delusion, illusion. I tell you more about that. That is actually very important in cognitive impairment in Parkinson's disease. And as you see, pain, genitourinary system, and visual system. At the end, cognitive impairment, that is main focus today for this talk. So before again get back to cognitive impairment, let's find out what happened that we get Parkinson's disease. The easy answer is at the end of this slide, a noun. I can tell you that I wish even we knew what we don't know. That's the scary part. I really think that we don't even know what we don't know. So that's why it put us in really bad position, in my opinion, because we think that maybe genetic has a role, and there are the long list of the new and more genes that are candidate for Parkinson's disease. However, with strong evidence about genetics, some of them even on certain specific like a ethnicity, majority of the patients that I see at clinic and Dr. Evidente see at his clinic are not correlated with a specific gene, even if we check that, even if we run the genetic test. So probably because some of them we don't know, or basically a majority are not necessarily genetic oriented, like related, and is not necessarily follow family history that they have Parkinson's disease. So another important factor, we have a tremendous amount of evidence about effect of environment. We have data about pesticide. We have data about like farmers, welders, because of the manganese, or veterans that got exposed to Agent Orange. The issue is that majority of the people that the also exposed to these environmental factors, they don't have Parkinson's disease. So therefore, there's always the battle. Is it environmental? Is it genetic? So as I said, the answer is a no. So however, what's the mechanism? Whatever is causing it, what happened that we get Parkinson's disease? One thing is that proteins is important. Why is important? Because our brain consists of proteins, and these proteins, some of them make the framework and the structure of the building of the brain, membrane, cytoplasm, and some of those proteins are neurotransmitters that communicate between cells of the neurons. So we have 1 billion cells in the brain, billions. And then these cells, why protein matters, I tell you, because whatever caused Parkinson's disease damage some of these proteins, and damage of these proteins, now the cell cannot function well. And what it does is affect the function of the cell. So therefore, they don't make those neurotransmitters that I'm gonna show you the list. And then you have consequence of that, you have a disease symptoms and presentation. So those proteins, there are like a long list of different proteins. The important ones that is specifically in Parkinson's disease, one of that is alpha-synuclein. And alpha-synuclein is a type of protein that is normally you and I, all of us, we have in our body, and it's a very important protein that has a role between neurons to communicate with each other. And for some reason, for whatever reason that I said at the beginning, we don't know, these proteins start to have a basically structure, and they fold, and misfolding of that protein make them probably dangerous from other area of the brain and accumulate in the cells. That accumulation, we name them Lewy bodies. And I show you some pictures here, that cartoon down showing that Lewy body accumulated the cells. And why is that important? Because pathologists can look at the Lewy body in the autopsies after death, and it says that, bingo, this guy had Parkinson's disease or didn't have Parkinson's disease. The same thing, we have beta amyloid is another protein, and which is also, we see beta amyloid in Alzheimer's disease, and tau protein is another protein that being phosphorylated and also in Parkinsonian patients. However, is not as amount of synuclein. So that's why we call Parkinson's disease alpha-synuclein disease. On the other hand, like Alzheimer's disease, we call it tau protein disease. So these are the things that you need to know. And I tell you why, because also these can help us maybe in the future with targeting them, can help us to do for improvement of cognition and help the basically disease states get slower, maybe, but also it's a big question mark on that. So these structured proteins, when get damaged and damage the cell, so therefore the production of the cells that are neurotransmitters get affected as well. So I listed here some very important neurotransmitters. As you see, the top is dopamine. We were extremely lucky in Parkinson's disease that relationship between disease and dopamine was discovered over a century ago. And almost a half a century ago, more than 50 years ago, we developed the medication that replaced the dopamine. So therefore, the patient cannot even walk if it's with no dopamine after, let's say, 10 years of Parkinson's disease, completely can be limited to his wheelchair. After discovery of that, we can give a patient dopamine and the patient can get up, and these days, we have patients that function at their best functional level. I have patients as the dentist, judge, pharmacist, businessman, and they are fine. They can do their job because with Parkinson's disease, you can function because we have medication that help us. Unfortunately, we don't have that situation replacing certain neurotransmitter to cure Parkinson or manage Alzheimer's disease. We don't have what neurotransmitter is low and manage ALS. So therefore, in Parkinson's disease, always I tell my patients, if after I deliver the diagnosis, I say that no, if among all these neurodegenerative disorders, you're lucky that you have Parkinson, because you can, with the proper management, you can continue your functional level. However, all these neurotransmitters are important is in Parkinson, not only dopamine. We know that these days that like a serotonin play a role in like a depression, norepinephrine, anxiety, acetylcholine with memory, glutamate, probably some compensatory mechanism also with hallucination, and some complications of the disease, GABA, probably some also with managing pain. Adenosine, these days, recently, we found out that we have an overactivity of this receptor, and we are using that to manage Parkinson's disease as well. And however, several of these are important in cognitive decline in Parkinson's disease: dopamine, serotonin, norepinephrine, acetylcholine specifically. So these are definitely get affected in cognitive impairment in Parkinson's disease. So now let me touch on cognitive impairment. And now from here, you see that gradually we're shifting to things that I'm talking overall about cognitive impairment applies a lot of them to same for Parkinson's disease. And the cognitive impairment can be at the level of subjective cognitive impairment or mild cognitive impairment or dementia. But before I tell you what are these, is important to know even what cognition is, because I'm going to talk about cognitive impairment. It's very fair that somebody here raised his hand saying that you're talking about impairment of something that I don't know what is that. Yes, cognition is mental ability that we use to process information and apply the knowledge. So let's translate that. So basically cognition is the ability that I have that you applying that information that I got from the past and learn, and now I can apply them. So that's meaning of cognition. So this process help us to manage our simple tasks or like even very complex tasks to do as a president or the CEO of the company. So for example, if today I wanna just after my talk go and drive, so I'm using the knowledge that I had from the past, I memorize them, I'm able to have visual spatial correlation between my car, my hands, the right and left direction. And also, if somebody's talking to me, I'm getting the direction, I'm looking the map. So all of these process needs the intact cognition for me to be able to do my job very well. So therefore, cognition needs the different part of the brain and domain. So for better understanding the cognition, we actually know that there are different domains in cognition that we can evaluate them. So I listed them here for you to and open them up and we discuss it. Attention is one of them, which is the area of the brain is the frontal lobe, which is the in this frontal part of your head, the brain, and also the sides, which is the parietal lobe. So memory is another domain that affect the inner area of the brain, like a limbic system. We call it hippocampus in an intrarenal cortex. And visual spatial functioning that again involve parietal cortex, and it's in fact depend on dopamine. Language is another domain, and executive function. I highlighted those executive function, visual spatial function, and also attention, because these are the area of domain that actually get affected specifically more with Parkinson's disease. And in fact, these different domain of cognition and understanding them help my colleagues, neuropsychologist colleagues, that when they evaluate the patients, then they come back to us and they say, okay, so this guy, it seems that has more attention problem, visual spatial function, and executive function. That's really highly suggests that this dementia is due to Parkinson's disease. Because, sometimes it's get very difficult. Somebody with Parkinson has dementia. You don't know this is the Alzheimer plus Parkinson is a Parkinson dementia. And if Alzheimer, then, for example, they have some specifically memory domain, some language domain. So therefore, This type of domain can also help us to differentiate between frontotemporal dementia, etc., which is beyond our discussion today, but I'm saying that also help us to differentiate those. So what is the attention domain? So the problem coming from ability to attend to relevant information while ignoring other irrelevant information. What do I mean is, again, when I'm basically, I was resident, I used to, grab my book after work and then go to sit in the coffee shop and study. So was a lot of noise, a lot of people go back and forth. This is my attention, that domain, that helping me to focus on my book and completely ignore the noises or some other people coming around and be able to focus and learn. So if I had the lack of attention, I couldn't pass from probably page 1 to page 2. So that's the domain of attention. And then what are the symptoms? Patient complain of the loved ones. They say, my dad is easily being distracted. He cannot keep the, track of lose the train of thoughts, and also difficulty multitasking, because multitasking also needs attention. What about memory? Memory also is another domain which we classify to different type of memory. We have short-term memory, which is the memory that, for example, you ask somebody, what did you have for breakfast? If they cannot remember it, is that the type of short-term memory? Long-term, like you ask them, okay, what you used to do? Where did you grow up? Where did you grow up when you were in your 20s? Where were you at? Or declarative memory, which is when we discuss about facts and data for touching on these domains. These are the way that we ask our patients questions in clinical exam. I ask them for the first time when I say, okay, who's the president, who's the vice president, who's the governor. These are the facts that I expect them to know. And then procedural memory is the type of memory that the task that you know and you learn. And if you cannot button your shirts anymore or tying your shoes, maybe the procedural memory got affected. So the problem is usually in encoding, because when we read something, then we encode it in the brain and store them, and now you need to retrieve this information and knowledge. So how the patient present or complain about, again, your patient coming with their loved one and says that my dad has difficulty basically remembering correct words. He forget, for example, we were in that park last week, difficulty with recognizing face or hard to learn the new information. These are the problem that memory get involved. Executive function, that is the ability to plan and organize, initiate, and basically initiate some goal-oriented behavior. The problem is that in planning, problem solving, also working memory and reasoning. And I told you example of, like, if, for example, a simple task the patient cannot do, or sometimes more complicated one they cannot, like they say, I figured out that my dad is not able to manage his finances anymore. He used to keep track of all expenses and payments, but now my mom has to be involved, or using the new gadgets, or basically difficulty with organizing certain tasks. So that's coming from executive domain. So the language is another domain that we name objects, generate words, and understand phrases. The problem is coming from production of fluent and spontaneous speech, comprehension of a spoken and written language. So basically the symptoms can be fluency of a speech. Sometimes I see that my patients, when are talking, words doesn't make sense. I had patients that he knew that. He said that I was professional speaker. I was very fluent now. And he was the one that he knew before even I can say, because I was thinking, no, he said that, no, this is not me. I really can talk better than this. And so he realized that something is cooking and basically affecting his that domain of language domain. Or forgetting words. He was sitting, said that I know this word, why it doesn't come to me. Or difficulty to being because remember, is not only what you say in the language, is what also you receive and interpret it, that's the language domain as well. And the last one I want to discuss is a visual spatial functioning. So sense of direction, understanding the distances between objects, perception, drawing objects, and that domain, which I told you, this is one of the domain that affect in Parkinson's disease. This is an example I can share it with you, that I have a patient I see at clinic, and I do one of the tests that I tell you that is a MMSE, that one of the elements, the simple thing is that drawing the pentagon. I personally get surprised sometimes that I'm testing the patient. I see that memory is perfect. They actually, the repetition and attention, all are good, language. And then I think that is over. So, okay, can you just copy this? Let's move on. And then I see that he has to spend, boom, block, and several minutes to just copy a pentagon. Or if I ask them that, just draw a clock and put the numbers around and handles, and he completely doesn't know how to do it. That's the visual spatial domain. So other domains are basically are not involved yet, or if they are involved, that simple test wasn't sensitive enough to detect them, but you see that in visual space, they have problems. So the problem is that understanding and manipulation of non-verbal, actually graphic information, and the symptoms again is a problem with drawing and interpreting, and difficulty even, like for example, using a clock because visual spatial doesn't work, or like they say that he was perfect in finding the places but not to get lost, and even cannot use map. These are the issues that patients complain about. So after saying that what the cognition is, that now we can basically classify our cognitive impairment to say that somebody has a subjective cognitive impairment or mild cognitive impairment or dementia. And what are those though? So the subjective cognitive impairment is the way that subjectively you complain and you detect the problem. Or for example, your physician detected, you say that, you know, I cannot find the word. I really was good in vocabulary, or certain things I read recently. I used to have a great memory, but now I don't remember it well. So however, even if we do, neuropsych test, when we talk about is sometimes there's a 2-session of 2-3 hours. So it's many hours of testing. And if there be neuropsych test with that details cannot detect anything and is only subjective, we call it subjective cognitive impairment. So which a lot of people like to say, okay, normal aging. I really don't like this word because I think instead of saying normal aging, it's better to say is something that we don't know about. So that's why you just blame aging on it. However, for today, you hear that a lot, probably people say, no, it's just a normal age. So therefore, this is a subjective cognitive impairment. And a lot of times you can find the cause. Depression, anxiety is very common, in my opinion, because every time people complaining about, say, oh my gosh, I have really bad memory. And then when you figure it out, you say, how's your mood actually? So that, really is not good. I'm down. And I explain it to them. I say, when you're down, you have a lack of attention. You don't want to even pay attention to anybody. You don't want to listen to anybody. So when you don't pay attention, you don't store anything. So then you cannot retrieve it, and then you don't remember it. And then you think that you have a problem with memory, but it's actually your depression and anxiety. So this is important. So therefore, every time with cognitive problem at mild level or like a subjectively is always good for screening for some depression and anxiety. What about mild cognitive impairment? So mild cognitive impairment, yes, you come and complain subjectively, or I see something is wrong. However, that is actually, you can find it is at least one of the domain are involved. If as a neurologist, I can detect it. As I said, my tests are not as sensitive as tools that neuropsychologists use, but however, in some simple tests that we apply as a neurologist, sometimes we are able to see that, yes, it seems that, as I told you, like that pentagon, I can see that, okay, the visual spatial domain is involved, or I can see that the repetition is involved, or for example, memory is involved. So you need at least one domain. However, we call it mild cognitive impairment when I see, and when I take the more detailed history, I see that the patient is able to get dressed fine, is still driving okay, still managing their finances, and basically they are not dependent, or their activity of daily living is intact. So that's the way that we say that you have mild cognitive impairment versus the next one I'm going to tell you is a dementia. So what happened with a patient with mild cognitive impairment? Somebody, people can say, oh my God, I have mild cognitive impairment and I know that I'm going to have dementia in a few years. That's not the case. In fact, some people can get better, especially if we can find what causing it. And then I think that's the area that we can do the most. A lot of emphasis is about mild cognitive impairment before you have a lack of motivation and completely dementia kick in. So therefore, without a lot of lifestyle modification, you can help in that aspect of the disease. However, some of them stay at the same and some of them get worse. Around 30% of patients, I put it here. However, you can read as much as even some papers come to even like 80%. So therefore, I'm always want to deliver good news and accept it from me that the 30% of the people with PD suffer from mild cognitive impairment. So when this mild cognitive impairment gets worse, then patient can come with dementia. So what is the differentiate dementia from mild cognitive impairment? You remember I said that in mild cognitive impairment, at least one cognitive domain and patient is independent. Here, on the other hand, dementia, when patient is not to the point that affect their activity, daily living, or cause dependency, then we can label somebody as now you have dementia. That's the differentiating factor. So what caused cognitive impairment? Cognitive impairments, one of them, I said subjectively normal aging, that which I really don't like it. That's why I put a noun. However, I talk about can be depression and anxiety. We have to do that. We always, for cognitive impairment, we check infection. Sometimes patient has like an old infection, sometimes sexual transmitted disease such as AIDS or like HIV or syphilis. Can be like a patient can have syphilis like a 30 years ago, went to the dormant phase, and now with the tertiary phase, which is the affect nervous system, they can present with dementia, and if we detect them right time, maybe we can reverse it. Excuse me, I even said dementia, cognitive impairment. And vitamin deficiencies, we always screen for them at the first place, make sure it's not a B12 deficiency, folate. Vascular is common. I think a lot of cases of cognitive impairment are due to mini strokes in the brain. They have like a patient's not controlled diabetes, high cholesterol, blood pressure under non-control, and they have mini strokes that it can cause memory effect, hypothyroidism, and Alzheimer's disease, of course, and PD dementia, which is that our focus, which is we talked already, we developed pretty framework about understanding about what cognitive impairment is. So Parkinson's disease, cognitive, of course, get affected. There are some important message here. One is that it's a slow progression. If you have Parkinson's disease and all of a sudden in a weekend, I receive a call from my patients and leave a message, and they say, oh my gosh, my dad is hallucinating, is completely confused, he doesn't even know who I am. So that is not basically mild cognitive impairment or Parkinson's dementia. So that is the condition that simply can be issued with infection, can be sometimes the simple UTI, can be like metabolic issues, dehydration in the summertime. I'm sure a lot of times Dr. Evidente sees that the patient with stable Parkinson's disease, all of a sudden patients completely reverse. Why? Is a 90 degree, 100 degree, and they not drinking as much and they get dehydrated. You check the test, you see that BUN and creatinine are very, very high. And a patient is in that condition. The stress can be emotional. Stress can be even like a patient goes to the big surgery and they feel that that's a stress to the body, and you can decompensate and present with the cause. So these are not example of regular cognitive, we call them like encephalopathy, then we can reverse them. So cognitive impairment has to be slowly go on, like as I said, subjectively, and then cognitive impairment, and if it's progressed, good dementia. And the message also I want to deliver to you that not everybody developed with dementia in Parkinson's disease. The same way that we, all of us, we are, no matter we have Parkinson or not, all of us are worried about if we get dementia when we get older. The same way, not everybody get dementia, correct? I have a patient, 100 years old, they come as sharp as my, like a 30 years old resident. And so that's the reason actually I didn't, is beyond this talk, but I personally think that we can learn a lot from all these old people, because we have to see what actually protecting them against neurodegenerative disorders like Parkinson. So not everybody get dementia. So therefore in Parkinson's disease also not everybody get dementia. So the thing is that we should be able to diagnose and screen for Parkinson patients. First, the full examination is required to make sure this is not a urine infection, this is not like a hormone deficiencies. And then we should screen our patients in the, as I said, sometimes very simple platform. The way that we use it as a neurologist, one of them is a mini mental state examination. The other one is a MoCA. Mini mental especially is a very, I can probably do it mini mental status in 2 minutes. And then, or maybe it's exaggeration, 2 minutes, maybe 3-5 minutes. And then MoCA takes longer. However, the specificity and sensitivity are low. So MoCA has a better sensitivity and specificity, but again, if you really want to have a good assessment for cognition as a baseline, or you see that how much is getting worse, that's the requires good neuropsych evaluation, which is our colleague psychologists, they do neuropsychology evaluation. So definitely can be done in the patients, regular patients that we see with Parkinson's disease. Also is important for us when we do certain procedures like a deep brain stimulation, we get some baseline and as well. Based on that, then cognitive decline, what happens that we have cognitive decline in Parkinson's disease. So neurotransmitters that I said is one of them and is really play a role. We know that low dopamine, interestingly, when you increase dopamine level, sometimes you see patients start to have some hallucination and cognitive worse, but sometimes increase of dopamine actually make the patient cognitively better. Low norepinephrine, the same thing. Low norepinephrine can cause lightheadedness. Sometimes cognitively, they make them groggy, but with the proper management, it can make it better. Cholinergic neurons is actually the main target for at least symptomatically control the cognitive impairment. And basically, cognitive impairment and PD is a PD cognitive impairment is a subset of Parkinson's disease, and or patients with mild cognitive impairment can have, like, for example, PD. What about genetic factors? There are some genetic factors that impact cognition in Parkinson's disease, the same way that genetic factors affect the general population. So again, there are some genetic variants that causing patients with Parkinson, they have more or predisposed to Parkinson's disease, and some of not. And so those are the way that it can be done, but it's not like a routine practice. So in PD and with mild cognitive impairment is first we have to diagnose Parkinson's disease and diagnostic basically, and then subjectively a patient has to complain, and then you have to make sure a domain is involved. So as you see, it's exactly what I said before. So for mild cognitive impairment, the thing is that here in advance, patient also has to have a Parkinson's disease. Then we say patient has Parkinson's disease with mild cognitive impairment. What about dementia? The same thing. So patient has to have Parkinson's disease, and then that domain shows that, and then effect of activity daily living. Again, I wanted to repeat, as you see that bullet on top, that not everybody develop Parkinson dementia. However, we know that compared to general population, it seems that there is a chance 3 to 6 times more that they can have it. What are the risk factors? We know that the patients that are older, they are more prone to Parkinson and cognitive impairment, or eventually maybe dementia. Basically, the disease that is more advanced already, if they have some cognitive impairment, so they are and then they get Parkinson, so therefore they can maybe be prone to dementia. The cases that start to hallucinate, and they the same thing, and also predominantly they have a gait dysfunction. I told you gait is when the gait is impaired initially in the disease, that tells you that, especially like a balance issues and freezing of gait, that tells you that it's probably some domain of cognition is involved. That's why patient is showing itself like that. So therefore, I said that the risk factors: older age, disease duration, severity of the motor symptoms, and postural instability and gait, baseline cognitive impairment, and other aspect of neuropsychiatric disorders. Hallucination, I said one of them. Sometimes it's not. Hallucination by definition means that I'm sitting here and I see a cat without any stimuli. Or I can have an illusion. That means I see this bottle, but I see it as a snake. So that object, I interpret it different, we call it illusion. Or also in the more advanced, patient can have delusion. And delusion means that you basically have a strong belief that is very hard to change it. Like I say that I'm sure that my neighbor gonna come and kill me. And I say that, no, you have the nicest neighbor ever. But that doesn't come out of my brain. That's a delusion. And some social isolation. So therefore, that's a reason that we really ask our patients be active. Some daytime sleepiness and lack basically sleep disturbances, mood disorders such as depression, and some actually even general systemic disease. We know that like a patients with diabetes or hypertension, obesity can have it, or certain diet, like a so saturated fat diets, refined carbohydrate, the diets that's a lack of nuts and vegetables, all these. And interestingly, also low serum level of uric acid, they can be as a risk factor. So how we manage the cognitive decline in Parkinson's disease? One is that medical, and one is that non-medical modalities. Medically, there are basically review their medications, because sometimes just certain medications, we get rid of them, the cognition gets better. Example, some medications that we use, we call them anticholinergic, for example, for frequency of urination, or some neurologists even use those medications for like a tremor. If we get rid of them, cognition get better. I noticed some of our medications like dopamine agonists sometimes cause hallucination and cognition decline. We can basically look at them. There are certain medications that we get to the point that we really have to simplify their medications. Other medical causes, if they have already, can improve it. And finally, there are some medications that we specifically use for managing cognitive decline. And for example, donepezil, for example, rivastigmine, which is among these medications, rivastigmine is the only medication has a FDA approval for mild cognitive impairment and Parkinson's disease. However, I personally use different ones as well, because I don't see significantly necessarily difference between rivastigmine, galantamine, or donepezil. And also memantine is another medication that medically we can use, even we don't have strong data and doesn't have FDA labeling. In my opinion, the most important element is that lifestyle modification, which we can call it non-medication modalities, which is that physical exercise, mental exercise. Physical exercise, I always tell my patient, is not just simple walking. I really encourage them to challenge themselves if they can even learn new physical activities, if they can, because their learning is also very good stimulus for our brain. So tell them, go and learn something new. And like a play ping pong, for example, or learn a new musical instrument. One of my recent patients, I said, that go and learn piano, and said that, no, actually, you know what? I just bought a guitar. I want to, so that's fine. That's perfectly fine. Just something new. Increase your social interaction. Sometimes this is the reason adult centers are great. If they get out of the house, go to these adult centers, listen to some topics that have been discussed, play cards, engage, being like a volunteer works. Good nutrition is very good, like such as like a Mediterranean diet and a good sleep hygiene. That's the very, very most important. The power of nap is a great. I always tell my patients, they say it when they take a nap in the middle of the day, it's like they are the different person. So there are some, I'm finishing my talk very soon. I don't want a Dr. Evidente get nervous that I gave a microphone to this guy and he doesn't live it. So I'm gonna promise wrap this up in 10 minutes and even maybe less. So recommendation is, one is mild stage of the basically cognitive impairment. As I said, that's an area that all we should have our main focus. And basically, this is an area, everything I say here is the people with no even cognitive impairment. We have tremendous amount of data about how lifestyle modification can help us against neurodegenerative disorders, well-being altogether. So regular exercise should be in our regimen. Stay active socially. We have a data that even patients that, or subjects that they have more socially involved, like in the urban area compared to if somebody in the like isolated area, they have like a more developed dementia. Cognitive training, some exercises, learning coping strategies, techniques. These are the techniques that I have to send the patients to occupational therapists or neuropsychologists to discuss it for our patients. And Mediterranean diet, take your time when doing tasks, let your family and friends know if you have a trouble, and seek help if you feeling depressed or anxious. These are the recommendation by Movement Disorder Society, in fact. And then in advanced stage, the recommendation is that develop the high structural daily routine that you follow, because remember, they know that. So therefore, try to have a routine to be able to do your task right. Using medication for cognitive impairment at this point definitely can help us. Have an advanced directive in place for living well, for treatments, for care partners. Take care of your own. I see a lot of times that my really concern is about my caregiver. She brings his husband, but I noticed that she doesn't have life. 24/7 is with the husband. So she definitely, we need to discuss, she needs to be well before can help her loved one. And so therefore, seek out support such as counseling is very important. So before I finish, the important question always I get when I'm basically at clinic, when it comes the problem with the cognitive impairment, that somebody bring it up, said, okay, doctor, do you really recommend that he should drive? So, because driving is a complex task, correct? So everything I said for domain of cognitive domain applies here: attention, visual, spatial, memory, actually, your process of speed, plus motor effect too. Like if they have like some stiffness, slowness of the movement can affect their driving. If I get to the point that patient doesn't have any question, or they're not questioning their driving, they say, that happened to me one time, that patients say just at DMV they are questioning my driving and I need to give them something for. I in fact sending them to my occupational therapist. They have a driving simulation test. Then I can nicely document that he's safe to drive, so nothing. But I personally have my own rule that I tell my patients. I say, nobody, I never go to my doctor. I don't go see Dr. Evidente saying, doctor, do you think I should drive? So I know that I can drive. If I get to the point that even I questioning it, or some of my loved ones are questioning it, my role is that I say, no, don't drive. because I see that probably you notice something, and driving is not only you put yourself in danger, you put society in danger. So my suggestion is to stop driving. So that's my own rule. But again, everybody has its own rule. That in this driving and Parkinson's disease is very actually an element that is not well formed. Like, for example, we have for the seizure disorders, every state has its own rule. For Parkinson and cognitive impairment in Parkinson, we don't have that. So this is it. So I want to thank you for your attention. Again, I want to thank Dr. Evidente, but we both, I believe, are open for questions for the rest of the time. Thank you.